So good afternoon all. Welcome to the afternoon session of our day 1 DPH Icon 2024. So we are going to listen an interesting speaker. As we all know, in the public health department, we are doing a lot of sample analysis, especially biological samples, and drinking water analysis, and any outbreak samples, including any genome monitoring, that is presence of dengue virus in mosquito and other things. The current focus is on wastewater surveillance, that we can able to predict before the occurrence of any outbreak. This wastewater surveillance is a current trend, and we are also on it. Through State Public Health Lab, we are planning to introduce that wastewater surveillance. In this regard, so we have a lot way to go. So we are keen to listen from our guest lecture speaker, Dr. Manoj Murhekar from National Institute of Epidemiology, Chennai. So over to you, sir. Thank you. I request the audience to please keep calm and settle down, please. So we are going to start the session. அனைவரும் அமைதி காத்து அன்புடன் அமருமாறு கேட்டுக்கொள்கிறோம். Silence, please. Thank you.
Good afternoon. At the outset, I want to thank DPH sir and the organizers for this invitation. Before I start, I also want to confess something, that I have never done wastewater surveillance, never involved in wastewater surveillance, but have read number of publications which talks about the strength of wastewater surveillance. And therefore, what I am going to do in the next about 30 minutes is going to give an overview of wastewater surveillance and present to you what it can offer, what this wastewater surveillance can offer as a complementary tool to the existing surveillance that is ongoing in the state as well as in the country. So I am going to talk or give a brief background about wastewater surveillance, its principles, why it's rational, and I am going to present to you some use cases of wastewater surveillance, and finally some of the challenges, and if time permits, I'll talk about some of the methods, but I really don't see we will have enough time for that. So now, globally, if you see, we have brought communicable diseases under control to a large extent with the use of antibiotics, antimicrobials, vaccines, various public health measures. But emerging and re-emerging diseases continues to be an important challenge, causing substantial morbidity and mortality. And there have been several reasons for these emergence or re-emergence of infectious diseases, and that includes increased human-animal interface, increased travel, urbanization, land use, climate change, etc. If you see the important emerging and re-emerging diseases in the last 20 years, these are some of the important diseases, which includes SARS, dengue, and recently we had COVID-19. And these diseases have caused substantial morbidity as well as mortality, and as well as a significant economic burden. And to control for these emerging and re-emerging diseases, we need a system to detect them early. We need a good surveillance system. Now, traditionally, if you see, there are two kinds of surveillance systems that are operating in India in most countries. One is the indicator-based surveillance system, where we do surveillance for selected diseases of interest. And there is the event-based surveillance system, where we surveil for certain events of interest. The important challenge of these surveillance systems is that the first challenge, I would say, is sensitivity. These systems are not able to capture all the events, all the cases that are occurring in the community. They are often not representative of the entire population, and therefore we often detect the outbreak very late. And by the time we detect already the outbreak is at its peak. Second important point is about health-seeking behavior. And we know that a lot of people may not seek public health care from public health system, may seek from either private or another traditional system, which may not be under surveillance umbrella, and therefore cannot be such diseases cannot be detected by a surveillance system. Another important challenge is that there are several diseases or several patients who are mildly symptomatic or asymptomatic, but may be shedding the virus or shedding the organism. And such cases are less likely or not likely to be detected by the routine surveillance system. And therefore, sewage surveillance system or wastewater surveillance system could serve as a complementary system for the existing surveillance system. So, sewage surveillance system or wastewater surveillance system is a type of environmental surveillance. And if you want to tell you the principle of this system in a simple word, is that anything that is shed in the sewage, either through feces or through urine or through respiratory system, can be detected in sewage. So this is the principle of sewage surveillance. And this anything could be pathogens, could be bacteria, could be viruses, could be chemical markers or drugs, or could be certain genes which reflect resistance to antimicrobials. So AMR genes could also be detected through sewage surveillance system. So there are certain important characteristics of wastewater surveillance system. It systematically analyzes the residues, that is pathogens, chemicals or certain genes in the wastewater. And irrespective of whether a person is symptomatic or asymptomatic, we could detect infection in, in the wastewater. And this is a very objective system. It is a passive surveillance system. But very important thing is it is representative of entire population. Because the sewage from entire community is going to come to one place, irrespective of the fact that whether this person seeks public health care or private health care. So in that context, it is a representative system. Now, let me go in the history and give some backgrounds or some origins of wastewater surveillance system. This has been used since several decades globally. It was primarily used for tracking fecal-orally transmitted diseases. And it has been extensively used for polio surveillance to complement the AFP surveillance. And in India also since 2012, we have been using sewage wastewater surveillance system in the country. Subsequent to polio virus, it was also extended to certain other pathogens, especially gastrointestinal pathogens, that is Salmonella, S. typhi, cholera, and certain viruses. But in the last 3 years, if you see, in the 3 years of pandemic, it was extensively used to track the presence of a SARS-CoV-2 virus in the sewage, including in several projects were conducted in India where they tracked the COVID virus in sewage. So these are some of the pathogens which can be detected in sewage with certain specificity and certain sensitivity. And these pathogens include certain bacteria like Campylobacter species, E. coli, Salmonella typhi, Shigella, and Vibrio cholerae. Some of the viruses includes adenovirus, enterovirus, including poliovirus, hepatitis A and E viruses, rotavirus, as well as norovirus. So certain parasites also have been detected in sewage. And several respiratory pathogens can also be detected in sewage. And we all know during COVID, several countries had a sewage surveillance system. Influenza could also be detected, RSV and other viruses could also be detected. Apart from viruses or bacteria, one could also detect chemicals or drugs in sewage. And this has been, this is one example where certain chemicals were detected in the close communities, such as prisons or juvenile homes, especially the certain drugs which are abused or misused. And you can see in this graph, like certain drugs like cocaine, ecstasy, amphetamine, and cannabis were detected in a prison population by doing sewage surveillance. So this is again a very important tool, a passive tool which can detect what is happening in the community. The drug consumption, what is happening in the community. As I mentioned earlier, there are several advantages of sewage surveillance over the routine or the indicator-based surveillance system. It does not depend on whether patient has access to healthcare. So it is independent of access to healthcare, a patient's access to healthcare, or testing capacity, and it is therefore not biased because whether person seeks healthcare or not. It is real time in nature, provided you are collecting samples with regular frequency, and it again can cover a large population. If you have a good sewerage system in the area, in the city, it can monitor several infections, several diseases, and in the long run, it can be a cost-effective proposition. So let me tell you one important distinct advantage of sewage surveillance system is that it can detect pre-symptomatic or asymptomatic transmission happening in the community. And this is example from COVID, SARS-CoV-2. And our routine surveillance system basically included surveillance in hospital which tracked mortality, which tracked about ICU occupancy or hospitalization. And our lab-based surveillance tracked about testing symptomatic patients. But in the bottom of the pyramid, if you could see, there are people who are infected, who were infected, and sewage surveillance system could detect occurrence of transmission or presence of transmission in the community at a pre-symptomatic or asymptomatic, when patient is pre-symptomatic or asymptomatic. So now, having given a brief background about sewage surveillance system, let me present to you certain use cases, and that will tell you as the power of sewage surveillance. And first, I'll talk about the use of sewage surveillance system in poliomyelitis. Now, we have two types of country now currently when we talk about polio. There are countries which are polio-free, which have sort of eliminated polio several years back, and India is one among them. And there are some countries where polio transmission is still happening, Pakistan, for example, or some of the neighboring countries, or some of the African countries. So in such countries, the role of sewage surveillance system is that it supplements AFP surveillance system in detecting the virus, and also provide increased evidence as well as confidence that circulation has been interrupted in the event it is interrupted. So let me give one example. So let me give one example from Pakistan. So this was in Pakistan started sewage surveillance system in 2009. And at that time, about 17 districts which were bordering Afghanistan, polio circulation was rampant that time. A lot of AFP cases, a lot of polio cases have been happening. And so they started a sewage surveillance system as a complementary, a sort of supplementary tool for AFP surveillance system. So as a part of that, they collected samples from different provinces and different cities every week. And this graph basically shows the virus positivity in sewage sample every week. And yellow indicates that sewage was negative for wild polio virus, whereas red indicates it was positive for polio virus. And as you can see in this graph, at least in 2011 and 12, there was wide circulation of polio virus, as was detected in stool samples. And as I mentioned, there are another type of countries which are free for polio. And in such countries, the sewage surveillance system can detect reintroduction of WPV or local circulation of circulating VDPVs. Eventually, they can monitor progress towards interrupting the respective outbreaks. So let me give one example again. This is from England. England had the last case of polio was detected in 1984. Since then, there has not been any case of polio, wild polio virus in England. And since 2014, they started sewage surveillance for polio virus. So they have been collecting samples on a weekly basis, sewage samples, testing for polio virus. And England has been using inactivated polio virus, the Salk virus, basically, Salk vaccine. They have been using the inactivated vaccine, IPV. So during sewage surveillance on 8th February 2022, they detected two polio virus type 2 vaccine isolates from London Beckton region. So two Sabin virus or SL, the Sabin-like viruses were isolated. And since the country was not really using oral polio vaccine, so this was not expected in the country. So what they did was they strengthened the surveillance. And since April 2022, they have been seeing more number of cases, as can be seen in the graph there. There was increasing number of proportion of cell culture flask with positive type 2 poliovirus isolation. So following that, they instituted a rapid response measure, conducted several rapid response measure activities. As I mentioned, they enhanced surveillance. They initiated IPV vaccination. And what they also did was, during this February to July, they isolated about 118 polio viruses from sewage. And this is basically the distribution of areas or communities where polio virus positivity was higher, that is indicated in the red. And in the yellow, again, it was a lower positivity, but polio virus was positive in the sewage samples. So what they did was they again did a whole genome sequencing on all isolates. And they found unique recombination in this isolate. So 98 of the isolates were found to be Sabin-like virus isolates, which are the vaccine, OPV type of vaccine, virus isolates. Whereas 20 isolates were the circulating VDPVs, circulating vaccine-derived polioviruses were isolated. So this is, and because of IPV vaccination, the transmission ultimately eventually came down. So this is one important use of poliovirus, the sewage surveillance, where one can detect circulation of poliovirus. I will give you one more example. This is the case in USA, in New York. Again, New York had last case of polio in 1979. In 2012 July, there was a suspected AFP case, a case of acute flaccid paralysis, which was from Rockland County. And as a surveillance protocol, they collected stool sample from this patient and isolated circulating VDPV from this stool. And then, because this was an isolation of circulating VDPV, a public health response was mounted, which included enhanced AFP surveillance, which included IPV vaccination. And since USA that time was conducting sewage surveillance for COVID, they also tested this sewage surveillance sample for polio viruses. So this is the timeline what happened. At day 0, you can see here, this probably is not working. At day 0, this patient developed symptoms of paralysis. And we know the incubation period of polio is about 7 to 21 days. And they interviewed this case patient and found that this patient attended a large gathering. On day 5, this patient was admitted in hospital, and day 11, the VDP was isolated from the stool. And then, as I mentioned, this sewage surveillance system for COVID was ongoing, and they tested these sewage samples for polio viruses. And at different time point, they detected polio virus from Wastewater in Rockland County. And the further genetic analysis indicated that the virus that was isolated from the sewage and from the patient were closely genetically linked, meaning that this patient essentially was infected locally, because this patient never had traveled outside USA. Not only that, they also found the polio virus in another county, this same virus was circulating in another county. Although the origin of this VDPV, vaccine-derived poliovirus, could not be ascertained, but they ultimately found that this was closely linked to the outbreak in UK and Israel, the UK outbreak which I just described. So this again is one important use of sewage water surveillance in tracking the infection. Now let me talk about SARS-CoV-2, and we all know sewage surveillance was extensively used for tracking the progress of the COVID outbreak, as well as finding out early detecting the outbreak. So let me give this example from South Africa, wherein they documented or they tracked increasing as well as decreasing trend of SARS-CoV-2. So they had sewage surveillance since initial stages of COVID pandemic. And by the week of 34, the Delta wave had come down, as you can see in the epidemic curve seen there. And environmental surveillance also showed virus at either it was not detectable or below the detectable level. But from week 43 to 45, again you can see that orange bar. They saw increase in virus detection, SARS-CoV-2 virus detection in environmental samples. And about 2 weeks after, there was another COVID wave in the country, and subsequent genetic analysis revealed that this was because of Omicron. We know Omicron, in fact, emerged in South Africa and it spread across the globe. So this is one example where they could detect a variant, or they could detect a virus in the sewage samples at least 2 weeks before the COVID wave of Omicron. And this is not one example, as I mentioned. Several countries used it primarily as early warning signal for impending outbreak. And very interestingly, there is a meta-analysis which documented or which estimated the lead time between detection of virus in the stool and occurrence of outbreak. And the lead time, as you can see, ranged from 2 to 12 days in USA to about 14 days in India. And there were several reasons for this variation in lead time, including health-seeking behavior, including the clinical testing sensitivity and so on. But what important point is that sewage surveillance can give you about 2 weeks time in advance to that impending outbreak is occurring. Okay, this is another example where one could also identify variants through sewage water surveillance. And as you can, this was environmental surveillance in Utah, where on 19th November they detected Omicron variant in sewage samples. And 10 days later, they detected cases because of Omicron in the hospitals. Again, a lead time of about 10 days. This is the example from Pune, where they have been tracking variants over last 2 years of pandemic, and you can see the changes, the tracking of viral variants during the pandemic. So this was about COVID. We all know that. And now let me talk about influenza. And this is the example from Canada. In 2022, the first half of 2022, when SARS-CoV-2 outbreak was occurring in Canada, there also was an outbreak of influenza. As can be seen that this is the curve which shows the COVID outbreak, and there was an outbreak of influenza ongoing in the country. So they again used the sewage surveillance system that was ongoing for SARS-CoV-2 and tested the sewage sample for influenza and detected influenza virus at least 2 weeks before the peak of influenza outbreak. Here again is the lead time, and as you can see, lead time for first detection of influenza virus in the stool and in the clinical case was about 17 days. So that is a big advantage for a public health system to respond. Monkeypox is another example, and we know now WHO has issued a has declared monkeypox as a public health emergency of international concern. And last year, when it was again declared as a PHEIC, and we know that most of the transmission occur because of sexual route. There's a lot of stigma associated with Mpox testing. And since this virus is shed in urine, in stool, it can be detected in sewage samples. So this is one example in Poland, and they started sewage in 2022, environmental surveillance, in 2 places, and they detected monkeypox genetic material on week 29 and 43 in first system, and during week 37 to 43 in the second sewage system in the country. Last year, there were 22 cases of monkeypox reported from the country, and most of the cases were during 28 to 32 weeks. And that time, there was no positivity in sewage sample. And the main reason for that was the sewage that is discharged from the hospital is chlorinated. It doesn't have basically any virus. So the presence of sewage, presence of monkeypox genetic material in sewage indicates that the transmission is ongoing in the country. People are not getting tested because of the stigma associated with that, and that's why you are getting the monkeypox virus positivity in sewage samples. This is the last use, that is antimicrobial resistance. Sewage sample can also be used to detect the level of antimicrobial resistance in the community by identifying genes, AMR genes. And this is one example from China, where they did large-scale sampling throughout China from 17 major cities, and they detected diverse and abundant resistant genes conferring resistance to almost all antibiotic bacteria, and they mapped this data geographically, and they found that there are certain areas where the ARG burden is higher, and there are the upper part or the western part basically has a lower burden of ARG, the antimicrobial resistant genes. And this again they correlated with the population density that is available in these areas. I'll just conclude in next 2 minutes, because we know the power of wastewater surveillance, but it doesn't come free. It comes with a lot of cost. And this is true because most of the environmental surveillance that happened during COVID, the funding for that ended, and there was a question how to sustain these surveillance activities. And therefore, a costing exercise was done in 12 countries where environmental surveillance was conducted in 12 LMICs. And they estimated the cost. It was highly variable across countries. The lowest was in India. The cost per sample was $34. And it was, in Costa Rica, it was about $500. But again, as you scale up, the cost decreased. And if you add additional biomarkers other than SARS-CoV-2, there may be only marginal increase in the cost and a lot of benefits by adding additional pathogens, is what the conclusion of this study. Sewage surveillance also has several challenges. It's not that it is a magic bullet. There are communities which either do not have any sewage system, and such example could be rural areas, or prisons, as we saw an example in Poland, or in hospitals where sewage is already treated. They may have a separate sewage system, and we may not be able to detect pathogens from these communities. Then again, the low level of viremia cannot be really detected in sewage samples. We may not be able to estimate the size of infected people in the community with the sewage surveillance system. So in summary, sewerage surveillance system can complement the ongoing indicator-based as well as event-based surveillance system. But the decision to implement or introduce a sewage surveillance system is based on three important components, I would say. One is we need funding for instituting a sewage surveillance system. We need a good lab expertise to do all the assays. And sewage surveillance system cannot be done by one single agency. There is a multi-sectoral engagement is required. And that is the third requirement which I feel is necessary if Tamil Nadu or if any state wants to introduce sewage surveillance system into sewage surveillance program into their surveillance system. Thank you very much, and I'll be happy to have any questions.
Thank you, sir, for enlightening us regarding the advancing public health system through our wastewater surveillance. The forum is open for audience for any questions. Yes, sir. Can you pass on the mic to JD Ministration, sir?
It's not a question, just information, sir. We are doing for polio, but we can extend for other diseases as you rightly mentioned. So we are doing with King Institute the sewage monitoring systems.
Yes, sir. Again, it's to complement sir's note. We already submitted a proposal to World Bank through Tamil Nadu Health System project regarding the wastewater surveillance, sir. So this is not a dream; it is a reality in near future. So we are planning on AMR also. With the drinking water surveillance, other things also going to be linked in that, sir.
Yeah, thank you, Vinay. Actually, in some cities, Pune is one example where they used the AFP, the samples that were collected as a part of polio surveillance or sewage surveillance for polio that was happening. And they had a surveillance, and the graph which I showed basically, the graph of variants from Pune was from the sewage surveillance system for polio that was used. So certainly, because we have I think about 20 sites where we are doing sewage surveillance for polio, and we can definitely add testing for additional viruses of interest to the country.
So apart from that, there is an NGO called Catalyst and Swasti is already they have done a wastewater surveillance in Trichy Corporation. Hopefully CHO Trichy Corporation might know it. So they are also going to provide technical support through NCDC, Ministry of Health and Family Welfare, sir. And this is the lead time which I am very much concerned. So it is definitely, it will save a life. In case of, if you predict an outbreak well in advance, that two weeks before, we definitely will move our resources and will reduce the morbidity and mortality of the community, sir. So hopefully we'll aim for the best. So thank you, sir. Thanks for your excellent, wonderful presentation and also coming here. Thank you, sir. Okay.
Thank you for your thought-provoking session, sir. Now I request Dr. Vinay Kumar, Joint Director, Immunization, to felicitate our speaker, Dr. Manoj Murhekar. I also request sir to present the moderator memento to Dr. Sendal, Joint Director, Communicable Disease. Thank you for moderating this session, sir. Thank you, sir.